trying to log on through my computer, but decided my phone might be better because I couldn't see the messages come through on the computer. So
yeah, it's easier to do on phone. Yeah. So
yeah, Instagram is like impossible on a laptop. Just the same thing.
No, but first we want to say thank you so much for joining us today. So
yeah, no problem. I'm excited to be here and talk with you all tonight.
Yeah. So for those who are following, we're about to start in 1 more minute, probably but we'll just start introducing who we are. So my name's Amber Park. I'm a current 3rd year at LMU, and Sarah.
Hi, I'm Sarah. I'm a 4th year medical student at Michigan State University College of Osteopathic Medicine.
Cool.
And then we want to introduce Dr. Kindel today, if she wants to introduce herself.
Yeah, sure. Happy to introduce myself. I'm Tammy Kindel. I'm an associate professor of surgery at the Medical College of Wisconsin in Milwaukee. I've been there since I finished fellowship in 2015, so for 8 years. And I have, I'm sure we'll kind of dive into this, but a basic science, translational science laboratory, as well as my clinical practice where I run our bariatric surgery program at Frederick Hospital in the Medical College of Wisconsin.
Nice. Congrats. You've definitely worked your butt off. So
we all do, but yes, there's it's, you know, every day I'm hustling, right?
Yeah, honestly. Other than what you do, what would you say is your journey prior to pursuing residency and just like general, like where you went undergrad or how you even got into?
Yep. So I'm a native from Ohio. My parents and grandparents were from Southern Ohio, so I grew up in Dayton. My dad was a pilot in the Air Force. I'm first generation from medical school, so it's kind of a, you know, a uniqueness that many of us share about, I thought I was going to be a veterinarian, which is what my mom wanted to do, who never went to college. And I quickly kind of pivoted in undergrad. I was at a small liberal arts school that's called Wilmington College in Ohio, and got a job as a phlebotomist. So I have great respect for our phlebotomy teams in the hospital. How hard that job actually is, but was very attracted to just the excitement of the hospital setting and felt like you could practice medicine to the fullest as a physician. So then I went to Ohio State for medical school, and I was kind of all over the map of what I was interested in, and I think, you know, having not come from a family in medicine, you know, I liked medicine, I liked surgery. And so it wasn't really until my 3rd year where I started to do rotations that I think I found my surgical personality and recognized that I was, those seemed to be my people, which I think is how a lot of us base that decision, right? Is just what makes the day go by and makes you excited to come back the next day. So I did like many of the surgical specialties, but ended up landing on general surgery to some positive interactions I had at Ohio State with faculty and honestly with the residents. I don't think we give our residents enough credit for how they shape the lives of so many medical students and falling in love with surgery and really why they choose that as a surgical specialty. Because, right, you're with an attending for, you know, maybe a couple hours for a case or a day every week, but it's that resident team that you're interacting with where you really get a sense of what the specialty is like. And so I was no different. That's kind of when I thought general surgery was right for me.
That's an awesome insight. I agree with you. I think the residents can like make or break your impression of an entire rotation depending. Yes. Yeah. And that's cool to hear that you're first generation doctor. I think a lot of us also share that experience, and it's different and it's difficult. So it's inspiring to hear. What the major theme of this series, I guess, we're exploring all these different subspecialties. So we want to know what specifically drew you to bariatric surgery and MIS.
Yeah. Well, at Ohio State, the way that they had the general surgery rotations, we did 8 weeks. And one of the pairings that I had was colorectal and bariatric surgery. That was like kind of lumped together with minimally invasive surgery. So I had a very early exposure to bariatric surgery. And I've shared this story with many people who've asked me, and even patients, because patients are always very fascinated about why you've decided to do bariatric surgery. And so I can remember being in clinic, and there was a woman who was maybe 9 months post-op. And, you know, I'm in there as a medical student, just kind of taking the history of how she's doing. And she shared something that she considered to be like a pivotal change in her health. And what she said was that she'd gone to the grocery store again for the first time. And so not really knowing what that patient's full medical history was, I made the assumption that that was based off of maybe mobility or not being able to walk through a grocery store for the first time. And then as we kind of went into the conversation, it was actually that she didn't feel embarrassed to be walking through a grocery store buying groceries for herself. And that was such a powerful moment for me as someone who has not struggled with body weight regulation, to not even really understand the depth of how this disease of obesity affects individuals in a quality of life standpoint, and also how they interact in society. There was nothing physically limiting her from shopping for her own food, but she felt shamed to be shopping for food in a grocery store. So that was kind of one of these like sentinel moments where I just felt such great empathy for this disease process. And bariatric surgery it's just such a fun profession because we're all about health and helping people get healthy. And so I got a sampling of that as a medical student. And then when I was a resident, I went to Northwestern for general surgery. And I think at Northwestern, we didn't have a bariatric surgery fellowship or an MIS fellowship. And so the residents were very, very active, especially as like a mid-level resident or a senior resident, with getting to do complex MIS cases. So I think that exposure, they're technically fun and challenging cases. And as a resident, to be very involved with them was also part of that building interest in bariatrics. And then for me, so at Northwestern, many of the residents go into the laboratory, about 4 of the 5 when I was going through. And so I actually spent 3 years in a research laboratory at the University of Cincinnati and got a PhD in pathobiology and molecular medicine. And my project was an obesity and bariatric surgery project. So like all the roads just came together at that point, and I've never looked back because I've been able to marry my clinical interest and passion in MIS and bariatrics with my research background, and that's created a lot of job satisfaction for me.
Wow.
Yeah. Sorry, go ahead. Oh, so I think that's fantastic. I feel like many people in general can't say that a lot of aspects of their lives can come together to their single passion. So,
yeah.
But go ahead.
Yeah. I think for many of us who are like, you know, I have almost 100% bariatric surgery practice. I mean, we really live and breathe bariatric surgery and obesity treatment. So I do think that's one of the uniquenesses of this field and some of the others, is that it's not just about like, oh, I like technically challenging surgery, but we're very, very into the disease process and understanding the disease and how we can treat it better surgically and non-surgically, and also from an advocacy standpoint. And I think that this generation of medical students and residents has a better appreciation for how important patient advocacy is, not just for our patients, but to prevent our own burnout. And it's been one of the spaces that I've been really pleased to be able to get involved in. I like to do advocacy for bariatric benefits for adolescent patients and just for general awareness for obesity and obesity treatment. And you might think like, well, gosh, don't you ever get a break from it? But honestly, it helps like renew me to want to do my job and keep studying and keep learning and working for these patients, the advocacy component. So I think for anyone, you know, and residency is long and it's hard, but when you're struggling a little bit with burnout, when you can find those outlets for patient advocacy or community engagement, it really does help renew you to come back to work the next day and keep trying.
So you were actually a surgeon scientist.
Yes, one of the rare, yes, I'm a rare breed.
That's crazy. Can you talk about that? Like, what is that like?
Yeah. Um, so I did, as I said, my PhD training during residency. That was 3 years. And then, there's like this abrupt transition back to general surgery residency. I had 3 years left. I tried to be involved. I finished up a few manuscripts, some clinical projects, but as a basic scientist, I mean, it's very challenging to stay involved in the actual lab while you're doing clinical residency. So I knew it was going to be important to try to re-pick this up very quickly, and I actually did that during fellowship. So I applied for a small research grant with the support of my mentors at the University of Nebraska, and was able to get a small clinical project going in the space of bile acid physiology after sleeve gastrectomy. And so that way, when I applied for a faculty position, I had some momentum of like what I wanted to be studying and how I wanted to do that. And it's a whole nother discussion of like, startup packages and research funding. But the way that it works like on a week-to-week basis is I do have a laboratory. I have lab staff. I have a PhD that works in my lab as a research scientist. I have a research resident right now. I have funding for a research technologist to kind of manage the day-to-day aspects of the lab and purchasing and our animal colonies. And that's about 50% of my time. And then the other 50% is the clinical, and I'll self-admit, I'm more than 100% of work probably, but that's kind of how the hours work out. You're always trying to multitask, which, as women, we do really well. So I think women are like great surgeon scientists because we're excellent at multitasking. And I try really hard to have like, when I do clinic on Tuesdays, like that's my clinical day. And I focus on that, and I have ORs on Thursdays and really focus on that. And then, of course, everything kind of spills over a little bit on the other days, but it's been useful to really try to block a little bit of my time to try to stay like honed in and do some deep work in each of those spaces to try to manage both of those things. Because as I'll say to like the PhDs that I work with, I'm trying to do both, right? Like I'm trying to be a full-time surgeon and a full-time researcher, and it is hard, but it's like so critically important that that surgeons stay involved in the surgical sciences. There is nobody that knows the translational problems like a bariatric surgeon does, right? I deal with these problems day in and day out. I know the patients, I know the clinical ramifications of what we're trying to do. And we have to have those people continuing to take those problems back to the bench top and sort them out. And if we stay siloed, the clinicians and then the researchers, we will have a bigger gap to fill than if we continue to find ways for surgeon scientists to do this work.
Wow, that is so cool. That is really fascinating that you have like one foot in
Yeah, in both worlds all the time.
That's really cool.
So going based off everything you do, how do you say is the lifestyle for just a typical bariatric surgeon who doesn't do research? And then for you, like how do you keep a work-life balance, or how do you prevent yourself from burning out other than, your patients and like what yourself?
So just a little bit about me personally, which I'm happy to share. So I'm married. My spouse is in medicine. He directs the heart failure and transplant program at the Children's Hospital of Wisconsin. So he does pediatric cardiology. And then we have 3 boys. So I had my first son my 3rd year in the lab. So during residency, but it was during my research years. And so he's 14 now. And then 4 years ago, I had twins. So I have twin boys, all boys in this household, only boy dogs. I've got a boy cat. At some point I got to get a girl in here, but it didn't work out for me yet. So that's kind of what I have going on, at home. I've got a professional spouse and then 3 school-age children. And I do think as a profession, bariatrics is very conducive to having work-life balance as a surgeon. One of the reasons is that we have a very, very low complication rate. So, and that fits my lifestyle needs and it fit my personality needs. Like, I want to be able to prepare for a surgery, know what's happening, be a technical master in that surgery, and have a very, very good chance of not having to have sleepless nights for days and days on end. So, we have a very low complication rate, a very low reoperation rate. And so I think that portends to a good lifestyle. I do, I take call for my group, but I actually don't take acute care surgery call or trauma call. And there just aren't a lot of bariatric emergencies. So when I'm on call, it's still very manageable. I can't go out of town when I'm on call, but I can go to my kid's soccer game and kind of still make weekend plans and those kinds of things. So I think that's been very conducive to kind of the busy life that I wanted to have with family. It's not the right niche for everybody. It's a very, very select kind of specialty where we're doing a couple of different cases primarily, right? Even if you're doing all the different types of bariatric types of surgery, there's only 4 or 5. And then revisional surgery is part of my practice too. So I think many surgeons, once they've been doing it long enough, they start to like revisional surgery because that's where things start to get a little bit interesting and you may not know the anatomy, but it's still elective. And even in revisional surgery, the complication rate is quite low. So I think that's helped me in terms of work-life balance. I was a college soccer player, so soccer's always been very important to me. I played in medical school, I played on the Ohio State club team. And then in residency, I had a really, really hard time making indoor games and pickup games. And so that's been something that when I got out of residency, I was really happy to be able to resume. And I'm lucky that my spouse has supported me in playing soccer games late on Sunday nights to play indoor. And we actually have a resident team now. I don't make the games all the time. Like this week, it's at 10:30. And sorry, but that's past my bedtime at 44 years old. But I still like to play some soccer here and there. And then I'm a huge, almost cult member of OrangeTheory Fitness. So I love my HIIT training, and I try to go about 4 times a week for HIIT training. And that's, because I'm in an academic practice, I know what my call schedule is going to be. I know when my clinic's going to be. One of the things that I've done is I just build in exercise time into my calendar. So people can't schedule meetings into it. It's a 45, 50-minute class, and that's my me time. And I think that since that's important to me and it makes me a happier person at work and at home, you have to protect those things that make you your best self. And it's rare that I have to cancel a class because of a work emergency unless I'm on call. So that's, I think it's a really nice lifestyle when you're trying to balance other things at home.
Yeah. I love OrangeTheory, just too expensive for me right now. So.
Yeah, right. Yeah, well,
for me right now, but you are peaking right now, so.
Right.
So you kind of mentioned as a bariatric surgeon, there's only a handful of cases that you guys do. Can you, for maybe those of us who are with us tonight who don't really know those surgeries, could you tell
Sure.
us a little bit about them? And then what is your favorite surgery or favorite that you do?
Sure. So in what I term primary bariatrics, we're talking about people who have not had a bariatric surgical procedure before. The most common surgery right now in the country is sleeve gastrectomy. So it's removing the greater curvature of the stomach. We remove about 75% of the stomach, either laparoscopically or robotically. And there's kind of a mix of surgeons who do either platform. And then gastric bypass, or room-wide gastric bypass, has also been around for 40 years, and it still has its place in bariatric surgery. There's some more malabsorptive procedures, something that's called a biliopancreatic diversion with duodenal switch that some select centers do. which gives the most weight loss and metabolic response, but also has a kind of higher long-term complication profile. So you have to find the right mix of patients and experience centers to do that. And then there's, some newer procedures coming up in the past, 5 years where we'll see what their space is going to be. One of those is like a loop or a single anastomosis duodenal switch where you have a sleeve anatomy and then a duodenal ileostomy like a DS, but no Roux-en-Y connection, and the common channel is a little bit longer, so less malabsorption. And then there's also a one anastomosis gastric bypass that's been approved by our societies as a newer procedure. So just some kind of modifications of some of these more historical procedures. And then endoscopic bariatrics is like a evolving space where balloons and endoscopic sleeve gastroplasty and then some revisional endoscopic procedures are also being trialed, and we're following the results of these for patients. But if you compare that to like a trauma surgeon, right? I mean, that's like how many, six, seven total procedures there. So most bariatric surgeons like to be like very, very refined down as like I'm expert surgeons in these couple of surgeries. And then revision. So you asked about favorite surgeries. I do like doing revisional bariatric surgery. They're harder cases, they're longer cases, they're more complex cases, but oftentimes the patients will come in really feeling either symptomatically, they're having terrible foregut symptoms, like let's say that it's someone who's had a vertical banded gastroplasty from 30 years ago, and they basically have a partial gastric outlet obstruction. And when you're able to revise them and give them such good GI symptom relief, as well as the benefit of more additional weight loss, those are really satisfying surgeries. But in really thinking about the patient population, that I find one of the most rewarding is actually our adolescent patients. So our program takes care of both adults and adolescents at our adult hospital as part of our accredited program. And adolescents would be, less than 18 years of age. And this is really just a patient population that pulls at your heartstrings as a provider, because they are just so desperate for durable results that will change their health, and adolescent obesity is very complex. They've often been obese since they were, a very, very young age. They don't even really remember a time often when they felt like they had a normal body weight compared to their peers. It has a high rate of depression, anxiety. They're socially isolated. Many of my teens have been bullied to the point where they no longer can really function in an in-person school system. And so it just feels like you're giving someone back a chance at a young adulthood experience and a fresh start. And those have just been some of the most memorable and rewarding opportunities for me to care for someone as a surgeon.
Yeah. Out of curiosity, what do you feel is the more prevalent risk factors for those adolescents? Would you say it's more socioeconomic, more almost like parental decisions, or how do you feel on that topic?
It's multifactorial.
Yeah.
I don't know if I've ever taken care of an adolescent that doesn't have a family history of obesity, though. So, and that in itself is complex because we call that genetic,
Right.
But then there's epigenetic modifications that have happened that are deep within socioeconomic status, medical health conditions of the mom during pregnancy, right? I mean, there's a lot of things that go into that. But so I'll just say genetic familial is almost always present in the adolescents. We do see higher prevalence in lower socioeconomic health status, and I think that's also, it's very hard to say why, what is the source for that, right? So is it access to food and healthy
Right.
food? Is it safe space to be physically active as a teenager or even younger? Is it societal stress, community stress? I think all those things are related. And then you compound that on someone who has a genetic or familial risk for overweight and obesity. And it tends to be a very aggressive form of obesity when it develops in teens. So there's some studies that show by young adulthood, these teens already may have cardiovascular disease or walking immobility or kidney dysfunction. So it just tends to progress at a rate that's even more aggressive than what we'd see if they had adult onset obesity.
Makes sense. So we're actually going to change a little bit of the topic, but we just want to ask more about you personally and how
Sure. Yeah.
how you prepared yourself for first like general surgery match, and how you prepared yourself to go into fellowship for bariatric surgery, or if you had to do anything different than the typical general surgery candidate to prepare for this.
Sure. I think that in thinking back to when I matched in general surgery, so that was 2005.
Mm-hmm.
I think, I know that rotations look a little bit different and things change, but there are still, I just think, some fundamentals of what helps you be successful as a candidate to go into general surgery. And I think one of the things that I had going for me is I wanted to be in the OR. And I think that speaks so much volume to the residents around you and the faculty around you, that as a medical student, if you're present, right, just showing your presence, that you're there, that you're paying attention. I'm always really impressed when medical students can start anticipating steps of a case, like they maybe know when we're going to look at something or what the next step in the case might be, right? To show your awareness without having to say that, you're showing your engagement. And so I think that my engagement was one of the things that I did well. I spent some time during the end of my third year wondering if I was going to do general surgery or plastic surgery. So I did a fourth year in plastic surgery, and then kind of was like, okay, yeah, I think general surgery is the right specialty. And then I was a little bit worried about my capacity to endure general surgery. And so I actually did a cardiothoracic surgery fourth year sub-I to kind of like show to myself that it didn't matter like the intensity of the case or the stakes, the intensity of the faculty, that I was going to be okay in this specialty, and I loved that rotation too. And so I think that so that kind of helped set me up for success in terms of applying and having a broad exposure. I did do an away rotation, and I know that COVID really kind of changed away rotations, and sometimes it's hard to do away rotations. I ended up not doing one. I matched at Northwestern for general surgery residency, and I did one at Baylor. And even though I didn't end up going there, it really was a great experience, though, to just see another medical school residency group, healthcare system. I only knew Ohio State and what Ohio State medical students were like, and the residents were like, and the faculty were like. So I think that helped me when I was interviewing understand programs a little bit better, and even some questions to be asking that might have been a little bit more insightful than those who've never kind of thought outside their healthcare system. So I know that those are hard, but I think just as an experience, not necessarily as like go there to try to match there, but just to be able to see something else is helpful to you to know what you're looking for, right? You see strengths of your own program, you see strengths of this other program, and it was helpful for me in interviewing. I know you had another part of that question, but I think I might have like went off on a tangent.
I think I just asked if you did anything else outside of just your general surgeon training to prepare to match
for residency. Yeah.
For your
yeah, not so much for matching, but I did do a late in my fourth year, I did an ICU rotation, which I thought was really helpful in prepping me for internship. So it's probably like the bariatric surgeon in me. Like I like to be exceptionally prepared for everything. And so anything that I didn't feel like I had exposure in, I just wanted to kind of be ready for internship. I ended up doing it this was just the uniqueness of Ohio State in the MICU rather than the SICU, because one of the MICU rotations, they didn't necessarily have a lot of students wanting to do procedures or residents wanting to do procedures. And I was like, me, I'll do it. I'll put in a central line. I'll put in an A line, let me do this. So that ended up being a great opportunity to get some procedural experience in as a fourth year. For applying for fellowship, having a PhD basically in GI pathophysiology and obesity was something unique that you wouldn't expect from most candidates applying to fellowship. But I think so I'm the associate fellowship director at our program in MCW, and when we're looking at fellows, the things that I think are shared though is an investment in the field, right? Like really wanting to see that people have kind of thought about this fellowship and what it means beyond I just want to be a technical expert, right? Because I feel like in bariatrics, you need to be more than that, right? And so I think, having joined a society as a candidate member in residency, so SAGES or the ASMBS are kind of two biggest societies that we're part of, having gone to those meetings and tried to present or participate even in a committee. Like many of our societies will sponsor residents as committee members. And so just kind of showing that investment, I think really helps you interview well and set you up for a good match in bariatric surgery and MIS.
Thank you for all of the advice so far. You've had some really awesome insights. And another thing we've been asking surgeons about is this theme of role models that you may have had, any mentors that you've had, and then how they've influenced you and how you obtain those sorts of relationships.
Yeah. There's been several, and so I'm always I hesitate a little bit because I don't want to leave anybody out, but I actually had a really meaningful PhD mentor for me. His name's Dr. Randy Seeley. He's now at the University of Michigan. And Randy's just this out of this world scientist and thought leader in obesity. And I felt really privileged to have him been part of my learning and journey. But I can remember early on meeting with him, and he kind of challenged why I was doing this and why why are you getting a PhD, and are you really going to do research? And I held on to that fire ever since then, that no, as I said, a surgeon scientist is so important, and I know that there are significant barriers to being able to take a PhD training long term into something meaningful for this career. But gosh darn it, you want to tell me it's going to be hard? Well, I'm going to do it. So I owe him a lot of credit, and he's been an ongoing part of my success in helping me kind of choose my topic for research here at MCW and mentoring me in some of my NIH applications. I had a hard time finding female mentorship throughout medical school and even residency. And so I really felt like it wasn't until fellowship that I had a real female mentor, and that was in Corey McBride, who was the bariatric fellowship director at Nebraska. And that's been someone who's been incredibly meaningful, I think, to me, from falling in love with being a bariatric surgeon. Corey's very devoted to her family and always prioritizing family and never making you feel bad for prioritizing family. I think when you're really hardworking and high achieving, you just don't want to ever let anything get in the way of those things. But the truth is, they get in the way for a day or a week or a month. But if you have that fire, like you'll get there. It's just, maybe I'm not going to get there today. And so, I've definitely had some personal setbacks and challenges. And it's because of some of those values that she helped create, where you just have to, sometimes you have to prioritize family first, and it's fine. And you should, you don't want to ever regret those kinds of choices. And I don't like to think that work suffers for it. I come back being a better surgeon and working harder when I've made the right choices for me and that work-life balance. So, and it's something I feel like I've tried to, as a mission for myself, because I feel like it's been hard to find female mentorship in our bariatric fellows that come through. I really want them to feel that part and never feel like they need to compromise on anything personally, right? If they have a drive professionally, they will make it happen, and you don't need to compromise anything personally to make that professional goal happen.
I have a question that wasn't listed, but you just made me think of it. So I know you said you started having a family during residency during one of your research years.
Yeah.
And this may be a very personal question.
That's okay.
I'm sorry.
I'm open. I'm really open book, because I feel like if we don't share our stories, nobody can learn from them. So it's fine.
So how did you make the decision to start having a family during residency? Because I feel like it is a very taboo topic still.
Yeah.
It's something that like residents are interested in knowing if that's what you're planning on doing when you're applying to their program.
So number one, nobody gets to ask you that.
Right.
Nobody gets to ask you that. And if someone's asking you, are you planning on having a family during residency? Don't go there. It's like it's none of their business, right? Like, you should get to have a family when it's right for you, and you share that if you want to share that. I mean, you have to, at some point, if you're pregnant, share that with your boss. But up until then, you don't need to share that with anybody. So to me, like, that's a red flag. Sorry. Don't ever feel pressured to share those kinds of personal things with people, because it has nothing to do with your professional capacity. So the first thing, right, is you have to be at a point in your life personally where you're ready to have children, right? So I didn't get married till the end of my second PGY year, and that fit with my needs. I wanted our relationship to evolve to that point. I actually tried to get pregnant much earlier in residency and research. I had 3 years, and it just didn't happen. And so third years is when I got pregnant, and I was grateful for the 8 months I had with Jonah before going back to residency. I think the much harder part about having children in residency is the childcare. The work hours, even though there's a cap on them and there's a cap on call, and this is not unique to general surgery. I mean, this applies to any residency. Makes childcare can be very challenging, especially if you have a support person who is also in medicine. So I think that was our biggest fear coming back to residency, was like, oh, who is going to watch this child while we're working all the time? And not everybody has family, and not everybody has a stay-at-home spouse, and not, right? So there are all these challenges. So I moonlighted when I was in the lab for like a year to save up money so that as a resident I could afford a nanny.
Oh my God.
And so that was our game plan, is we were going to have a nanny, and in Chicago, super expensive, but I'd been planning and saving for that as a strategy. And then my spouse finished his sub-fellowship and became a faculty member. And so his time got a little bit easier. Our salary got a little bit better, so that we could make, a nanny not so unmanageable for the last 2 years of residency. Then I went to fellowship, MCW, I did struggle I wanted to have a child earlier than that, but struggled to get pregnant and had some miscarriages. And so by the time it was kind of like, are we going to have another kid? I ended up needing to do IVF. I'm happy to talk about that if anyone has questions about IVF. And then got pregnant with twins. So a twin pregnancy is very, very hard. I was glad I was a faculty member and not a resident. But again, like, I think that there's no easy time, especially in general surgery, in medical school, right? There's no easy time to get pregnant. And so be in the part of your life where you've got a partner or not a partner, but it's the right time for you to have a pregnancy and a child. Make sure financially you can afford that child, and everything else is going to fall into place. I really do believe in 2023, 2024, people are going to help make it work. It's more and more common to see pregnancies in residency, pregnancies in medical school, and we have to normalize this. Like we have to stop making it be the exception, and it's the standard, right? That women of childbearing age are going to have children.
Right. It's like one of those things, you have to be the change that you want to see, right?
Right. Absolutely. And, I had this conversation with my, my husband, as I was a resident, and I had a co-resident who was pregnant. And then my chief year, one of my co-chiefs adopted, but there just weren't a lot of like examples of how to do this. And I felt like a lot of the venues that I went to and were trying to look at women older than me who had done this and walked the walk, that they had partners who were at home or worked at home, and I just couldn't figure out, like, well, how are we going to make this work, And we both just said, like, I'm just going to have to pave a road that works for me, and it may not look like the road that anyone else has done, but it's going to have to be the road that we make work. And I think for most people, there's enough individual differences in relationships and locations and family support that you are going to have to pave your road a little bit independently. But you're right, it has to be normal, and just normalize it.
And Dr. Kindel mentioned, like, nobody should be asking you about family planning. And I know, at least at my medical school, we were advised, if anybody asks, like, you do not have to answer that. You shouldn't. And I think it's actually an illegal question. It cannot be asked actually legally through the match. So just in case anybody is about to go through interviews like me, you do not have to answer that, and you shouldn't.
Correct. And even if it's done right in a formal interview process, right, that shouldn't be asked. But I think that, sometimes we get in these spaces, breakout rooms, I people don't like meet in person anymore, but even if it's done in a more casual way, you really should not ever feel forced or pressured to answer that question about any aspect of your personal life that you don't feel comfortable talking about. You want to be an open book like me, and I'll just tell you what it is and who I'm with and what's happening, like, that's on me. But no one has a right in an interview to ask me that question if I don't want to give that information.
I really appreciate you sharing that, being just so passionate about it. I think a lot of people, especially myself, struggle with not only like prioritizing family, but learning how to really balance everything, especially if we have strong drives and wanting to succeed. So I think that was very helpful. But we're probably...
I'm gonna just, if I could just say one more thing about that. Like, just be okay also with sometimes getting it wrong.
Yeah.
Right? Like, we have to give ourselves a little bit of grace that sometimes we're not going to prioritize as well as we would have liked, and we're going to make the wrong decision. And I still regret to this day, the day that I started my faculty job here, my son started kindergarten, and I didn't see him on the bus because I just felt like it was my first day as a faculty. I had to be at work. And I regret it to this day. Like, sometimes we're going to make the wrong decision with the best intentions, and you just have to next time learn and do it better.
Yeah. No, we really appreciate that from you. So, but we're going to start wrapping up just because for saving your own time and for everyone else. But before we go, what would you say is like one tip you would give to any first year intern starting general surgery?
As soon as you can, learn the difference between someone who's like a normal post-operative pathway and someone who's going off the pathway, right? Like that skill of something doesn't feel right about this, something doesn't look right about that patient, something just feels off. Like you don't have to get it all figured out, you know, in your first month. You don't have to know how to treat it, but the sooner you can just get that sense of this is not normal, this is not the way most of our postoperative patients behave, and elevate that up, the better you will be as a physician and the better your intern year will go. Because I feel like most of the issues that we see are related to not recognizing illness, right? Not recognizing sick, not loading the boat, right? That load the boat, get people, you know, and I think when you're starting internship, being more cautious than not for that until you do get that better sense of, no, this is okay, will serve you really well and keep people healthier, and that will help you perform better.
Oh, I love that advice. That was actually fantastic. And just for our viewers, some I think asked questions that we weren't able to address. Would you be okay if people DM'd you, or if we tagged you so people could possibly reach out to you via?
Yeah,
Okay.
most definitely. So I think you see my Instagram handle. I don't even know what we call that on Instagram. Yeah, I'm revealing my age. But you can DM me, or please just reach out to my work email. It's tkindel, Kindel, at mcw.edu. Any questions?
Perfect. Now I'll put that.
Okay, we will make that available. So we're going to go ahead and wrap up. Thank you, Dr. Kindel, so much for your time. We know you're very busy, and we really just appreciate you volunteering your time like this and for being so candid and having such awesome insights and advice for everybody. And thank you to everyone who joined us this evening. Again, this has been our monthly Instagram Live subspecialty series. We host it every first Monday of the month at 7 p.m. EST. It's an awesome opportunity to stop by and hear the voices and journeys of women surgeons in all different specialties. And next month will be hepatobiliary surgery. So if you are a hepatobiliary surgeon and you want to share your story, let us know. We would be so happy to have you.
I saw Melissa Hogue join, so I'm going to give her she's an excellent hepatobiliary surgeon in Chicago. So if she's still on, then I'm going to pull her out for this one.
Let her know. We would love to hear from her.
Will do.
Thank you so much again, Dr. Kindel. It's been so fun.
Thank you, everyone. It was really great. Have a good one.
Same to you.
Bye.
Bye-bye.
And to our viewers, we're going to end this, but thank you guys so much for hopping on. So good night.
Amber, thank you so much.
Yeah, girl. Thank you.